Hi everyone, this is Neil Wright-Atair, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient with extremely hairy ears, and there's so much hair matted onto this plug of wax when I eventually removed it. So this is the patient's left ear. They had used some drops prior to attending, so hence why it's glistening a bit just at the surface. So I'm going to try and elevate this off the floor on the posterior canal walls of the back section. Now, in their left ear, we have made a priority referral to ENT because they are currently suffering from otitis media with effusion, also known as glue ear. And I'll explain that in more depth and the rationale behind the priority referral. But before I do, I just wanted to say a few words on yesterday's video that I uploaded. I haven't uploaded it on YouTube yet, but all other social media platforms. But yeah, on Facebook, I got lambasted for it. It was just quite shocking. So that was, for me, one of my most technical procedures. I was extremely pleased with it. And the reason for that is that patient in yesterday's video had extremely hardened keratin right lodged up against their eardrum. And to remove it, I had to use an ear plug and an ear hook. And a lot of people saying, why didn't you use it before? Well, when it's that deep in the ear, right up against the eardrum, it can quite easily cause some serious trauma to the eardrum when you're using, put aside the ear hook, but especially the ear pick because of the angulation. And there was no gap. So I know a couple of my colleagues read the comments and they says, well, we wouldn't have even attempted to do what you did. So yeah, it was quite comical, but I just thought I'll raise that because it was quite, a bit surprised. Just goes to show that some of the videos that I feel are technical, and that was genuinely one of the more difficult ones. I don't think some people in the public domain have an understanding of what we do and how complex it is. Anyway, moving on to back to this one. So I've removed that lateral plug. As we get deeper, the wax is getting a bit darker, so it's more aged, it's oxidized. There's also less natural oils and sweats that are normally secreted in the outer third of the ear canal that, of course, can then enter the deeper part to moisturize the plug. So then wax deep in the ear typically is a bit dry and harder, although sometimes you can have the reverse effect. There's a lot of humidity deeper in the ear because of the occlusion that can cause the wax to become quite soft and mushy. You can just see these hairs. These are called terminal hairs. We normally have two types of hairs. We have vellus hairs, which are like the hairs on a peach. They're really soft and almost invisible to the naked eye. And these terminal hairs are a lot thicker. Vellus hairs normally are sort of thin peachy hairs, generally help to keep us a bit warm because air can get trapped in between the hairs and it warms up. And also they do secrete sebum, which is a lipidy oily secretion. Terminal hairs also can secrete sebum, but the hairs at the entrance of the ear, they're more protective in a way. They're trying to stop foreign invaders from entering the ear. So I'm just going to pause this in a few bits. So first of all, we can see their eardrum is retracted. They've got a retraction in the attic, so the top part where the short process of the malleus bone is, and also the posterior superior quadrant. You can see the posterior malleolar fold is quite prominent. You can see this air bubble posteriorly about 3 o'clock, and at 6 o'clock you can see that amber fluid behind the eardrum. So that fluid is not infected, it's sterile fluid, and you normally associate that with otitis media with effusion, also known as glue ear. If the eardrum was inflamed, it was red, and you have kind of a whitish appearance behind it and it's bulged, and the patient has reported an upper respiratory tract infection, we call that acute otitis media. So that discharge behind the ear is purulent, it's infected, where in this case it's not, it's sterile. And the reason for that, the referral to ENT, is if an adult patient attends and they have unilateral, so in one ear, sterile fluid behind the eardrum, and that's normally caused due to a blockage of the eustachian tube at the back of the nose, which creates a negative pressure in the middle ear. So all the remaining air in the middle ear gets absorbed by the cells that line the middle ear. That then causes fluid in the middle ear cells to be excreted into the middle ear, and because it can't drain out the eustachian tube, it collects. And one potential cause for that is a nasopharyngeal mass at the back of the nose, where the eustachian tube connects at the back of the nose. And a nasopharyngeal mass can be benign, so non-cancerous, but it can also be malignant. An ENT that I spoke to recently has come across a case where a patient has had an adult patient has bilateral otitis media with effusion, and it was due to a nasopharyngeal mass. It was cancerous as well. It was extremely large, and it blocked both eustachian tubes on either side. So you can see all those hairs, but we're going to get the eardrum in focus. In this side, there's no fluid. The eardrum is slightly retracted, so they have got a bit of a blockage there as well. But we've made the referral. We have to do it by their GP. So that's all the wax. You can just see how hairy it is. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.